Good morning. I thank the organizers for giving me this opportunity. At the outset, I thank Professor Butcher for making my job very easy. I thought initially he's talking for MRI. I was very surprised. And I think he has spent most of his time with MRI, and he would definitely agree that it is far more superior. As you know, the stroke imaging, the concept, the practical and technical aspects, and MRI is superior, and the BOSS and the multimodal CT is futile. I will show you how it is. So if you really look at the pathophysiology of stroke, if you very carefully look at this, even when the cerebral perfusion keeps falling, because of the autoregulation, the cerebral blood flow is fairly well maintained until some particular point where the oxygen extraction fraction starts rising when the cerebral blood flow starts falling. These are all very important parameters when you want to see the stroke, because there is a paradigm shift where we're shifting towards the metabolic imaging rather than imaging the pipes and the penumbra. The three failures which I want to point out here is the metabolic failure starts at approximately 40 ml per minute of CBF. And that's where even clinically the patient starts weakening. But whereas the membrane failure is only about 10 ml per minute per CBF. And that is where the ionic swelling, the intracellular swelling, all these things, that there is a gap here even in the imaging. This gap between the metabolic failure and the membrane failure to pick up the early strokes. This is exactly what it is here, which I have depicted. You can see that at this point of time, you require up to 10 ml, it has reduced to be picked up by diffusion weighted imaging. So among the four images, the perfusion, the penumbra, the pipe imaging, and the parenchymal imaging, what I want to stress is, this is based on the gold standard for the metabolic imaging, is the PET. You look at this, in core everything is reduced. In the penumbra, you can see that oxygen extraction ratio keeps going up, and the CMR2, once it starts decreasing, it makes it. So you require the oxygen extraction ratio, CMR2, are important parameters which you have to image in future. So you know how complex the stroke metabolism and the intervention is going to be, all the more complex. So is it perfusion and protection, the two sides of the coin? It is just not enough that you do identify the penumbral imaging and showing the mismatch, and it is going to be metabolic in future. So as my opponent has already shown you that penumbral imaging, MRI is far superior in his talk, and I don't have to spend much time on that. But what I want to stress is, by inner parenchymal imaging, the imaging of dead tissue is role in rehabilitation using the conventional MRI. We then shifted to the penumbra imaging, where you see look at the diffusion weighted and the perfusion weighted mismatches. And then there's also the pipe imaging, where you look at the vascularity of the vessels, large vessels, and then for the endovascular. And then now the shift is towards the imaging the tissue metabolism and the role in the neuroprotection. Even though, as Professor Bornstein told, that we used wrong parameters and the trials were a lot of failures were there, but I think still this protection has got a lot of role. If you look at the toolkits here, the multimodal CT, which my opponent said, which includes cerebral blood flow, cerebral blood volume, the MTT, mean time to transit and time to peak, and cerebral blood flow, all these things, using a 320 slice scanner takes 10 minutes, whereas stroke protocol MRI takes 12 minutes, and this the 1.9 billion neurons which he talks, I'm sure, he's not sure whether they are dead. They may still be salvageable. And 2 minutes time, I think on the long run, where a quality imaging would give you better options. So if you look at the MRI, you can do cerebral blood flow, cerebral blood volume, MTT, time to peak, ADC. Using arterial spin labeling, measure cerebral blood flow. Using MRI-based oxygen extraction, that one I was telling you, OEF, the oxygen extraction fraction, and the cerebral metabolic rate of oxygen, which are going to be very, very important imaging parameters in future. And not only that, the MR spectroscopy would really categorize the biochemical aspects of the penumbra, the core, the oligemic zone, and the normal tissue biochemically. So all these parameters are possible by using MRI. So if you look at the penumbral imaging, the operational criteria is hypoperfusion less than 20 ml, abnormal neuronal function documented by correlation with acute clinical deficit, physiological and biochemical characteristic consistent with cellular dysfunction but not death, uncertain fate and salvage of tissue with better clinical recovery. This is the operational criteria for penumbra, and all this can be effectively imaged by MRI. Hypoperfusion less than 20 ml, you do absolute cerebral blood flow values with perfusion weighted image. TTP more than 4 seconds delay corresponds to the PET-derived CBF of less than 20 ml. So by using an MRI, look at TTP, which is more than 4 second delay, which is equal to reduction of CBF. So look at the second criteria, the volume of diffusion weighted lesion and perfusion mismatch significantly correlates with the clinical severity. The third thing, the physiological and biochemical characteristics consistent with cellular dysfunction but not death, which again be depicted by ADC and the DWI lesions. And so uncertain fate with early reperfusion, the risk to progresses to full infarction is prevented. So between the man and the machine, the practical and the technical issues, you know that clock is ticking and you want to reperfuse, and with risk of hemorrhage, you're walking on a tightrope. And within 3 hours, there is yes, very clear yes, no, and yes and no. But what are these situations where nothing like MRI, a wake-up stroke where you don't know, lacunar strokes, improving strokes, posterior circulation, and presence of associated microbleeds, and nothing like MRI where your CT has got, it can't detect. So most of the trials, which in fact Professor Ken Butcher and Stephen Davis have done epithet trials, and all of them used the penumbral imaging. Most of them were on MRI based. And what I just wanted to show you is one more thing, is this silent brain infarction and stunned brain by serial diffusion perfusion MRI clinches the stunted brain. What is this? See, what happens is, if you look at this, when you reperfuse, there are 3 patterns which emerge when you after post TPA. The one is which shows an early dramatic improvement, and second is an early recovery in spite of reperfusion. That is the Tmax of less than 2 seconds, Tmax between 2 and 8 seconds, and Tmax beyond 8 seconds. The 3 categories evolve, and the last category, more than Tmax more than 8 seconds, there's not going to be any recovery even if you reperfuse the tissues. Whereas the group which is dramatic is going to be Tmax of less than 2 seconds, and the group with a late recovery in spite of reperfusion. So all these 3 patterns you can assess only by doing an MRI. So what is beyond thrombolysis, as in the diffuse 2 trials, I said the target mismatch, patient had early reperfusion, and endovascular treatment had more favorable clinical outcomes. So to conclude, what I want to say is there is a role for neuroprotection. It is just not reperfusion. There is something beyond that. You reperfuse and stun brain, you want to kick the neurons up and working. You need some other strategies to look at these areas, and MRI metabolic imaging shall be the future. And since it can prognosticate, it has an influence on the outcome, it is available and feasible. Side effects and contraindications are pretty less. Using an endogenous contrast like BOLD versus an iodinated contrast, I'll just show you the MRI is definitely superior on the BOSS. And this is an old slide. I already talked to you. And just look at this whole thing. I would summarize this. If you really look at the ICH, the diffusion weighted imaging, it's in ischemic stroke, the sensitivity specificity is pretty high as compared to a multimodal CT. Diffusion weighted is definitely superior. In ICH, the gradient echo is as good as MRI, even though the non-contrast is standard is the one which still is comparable, the results, and look at the penumbral imaging, diffusion-weighted, perfusion-weighted mismatch, and continuous arterial spin labeling. It is definitely superior. As I told, the CTP limited. Now, even though the newer scanners with 320 slice, the coverage is wide and not the entire brain can be covered. But again, the question of availability of 320 scanners in various centers is, I'm doubtful. Regarding the metabolic profile, as I was telling you, the oxygen extraction ratio and the CMR2, MRI alone can do and CT is not possible. And as far as the vascular imaging is concerned, MRI is as good as a CT angiogram. So multimodal CT, I am going to take this futile, and MRI is accurate. And secondly, I also want to point out what is the radiation hazard by using a CT. 16.4 millisieverts. Risk of fatal cancer is 5% per steward, and as per CT, multimodal CT, it's 1 in 1,200 for 16.4 millisieverts. And contrast-induced nephropathy, 2.3%, more so if CT perfusion is also done. Would you like to take a multimodal CT or would you like to do an MRI? I'll leave it to you. Thank you so much for your attention.
Thank you, Professor.